Thank you very much, Mr. Chairman. Dear colleagues, first of all, I would like to thank you, the organizing committee, for this kindly invitation to participate in the third annual International Congress of the Egyptian Fertility and Sterility Society. As you can see here, the title of my presentation is "There is Epigenetic Factor Which Affect the Descendant from ART." This hypothesis started in 2012 when in the Journal of Focus Reproduction of Escher, there is a publication that the in vitro culture of human embryos in the medium from commercial medium Cook resulted a singleton with a lower weight during the first 2 years, about 500 grams of the life, compared with another commercial medium from vitro life, as you can see here in the graph. The same time of period, there is paper that showed that the ART babies have a picture of hypomethylation of DNA. Thus, the hypothesis is that the IRT, the culture media that we use, also the drugs that we use during this procedure, probably has some cause in the DNA methylation and create a abnormal placenta development and function, and as a result of this is to produce baby with IUGR or low birth weight, CGA, fetal overgrowth with the fetal grease, and finally we have premature birth and perinatal death and long-term diseases. And in 2028, there is a sophisticated paper published in Human Reproduction, and the question was to answer if do assisted reproductive technologies after DNA methylation and or transcript of transportable elements and the imprinted gene in the cord blood and placenta. And they find that DNA methylation level as H19, IGF2, KNOT1, line 1, and ERVET1 were significantly lower in IVF equal placenta than in the control placenta that received natural. In order to answer in this question, our department conducted 6 studies with this subject, and the group were 363 babies that born after ART, and the age was 10 to 14 age, and the control group was 285 natural conceived babies. We looking for the metabolomic syndrome, for cardiovascular risks if they present the PCAK protein, and also we examined the profile of proteomics and metabolomics. The first paper was published in 2010 in Fertility Sterility, and the title was Absence of Insulin-Resistant and Low-Grade Inflammation Despite Early Metabolic Syndrome Manifestation in Children After Born in Vitro Fertilization. We have 160 babies, and we showed that the birth weight of the babies compared with the control was significantly lower. The birth length, the weight was also significantly lower, and AGA and CGA was significantly different with the control group. Also, we found that the preterm delivery, less than 37-week gestation, was significantly lower in the babies of IVF, and also we found that the systolic and diastolic pressure, as compared with the control group, in the babies with IVF was significantly higher, and systolic and diastolic pressure. Also, we found that triglycerides level was significantly higher in IVF babies. On the other hand, when examined the glucose or the fast glucose insulin ratio, and the other parameters, and insulin and adiponectin, and the inflammation marker, the CRP, interleukin 6, we saw that was no different between the babies that born with IVF or with the natural conceived. However, in this study has demonstrated that children born as a result of conventional IVF had significantly higher systolic and diastolic blood pressure and triglycerides as well than the control. No significant difference in biochemical incidence of insulin resistance, including fast glucose to insulin ratio and circulating adiponectins or low-grade chronic inflammation markers. The next paper that published in European Journal in Clinical Investigation 2013, we examined the RB4 and NAGL that both of these proteins are associated with glucose intolerance and could help the early detection of metabolic abnormalities. We found that when the males in the prepubertal boys, NAGL was no significant difference between the two groups. On the other hand, with the pubertal boys, we saw significant higher the NAGL, and when we compared PRB4 in the girls, we found that in IVF in the prepubertal age was not significant, and after the pubertal age was significantly higher. What means this? That IVF children had significant higher PRB4 and NAGL level than in the control, suggesting early metabolic derangement that could be attributed to an epigenetic phenomenon. These results are in accordance in the previous study I present to you, where the blood pressure and triglycerides was higher. However, further prospective studies in IVF children will determine the natural course of their metabolic profile. The next paper, published in Journal of Assisted Reproduction in 2029, and we examined the PCAK and lipoprotein in children born after assisted reproduction. Both the PCAK protein and lipoprotein are associated, in the future will be the person who carries this a cardiovascular risk. We showed that a significant interaction was found in age group, and the conceptual measure showed that the PCAK level increased from the age 8 to the 10. On the other hand, in natural conceived babies, this protein was declined. On the other hand, we find regarding the lipoprotein that the IVF children, the conventional IVF, present high level of lipoprotein as compared with the baby that conceived with a natural way. On the other hand, when compared IVF and the control, we found also that was higher level of lipoprotein. However, the PCAK level increase with age of ART children indicate a gradual deterioration of lipidemic profile that could be lead an increased cardiovascular problem in the future. Moreover, our result indicated ART method may be an importance given that classic IVF is associated with high level of lipoprotein alpha. In this paper, we published the profile of children that born after ICSI procedure, and we found that the study was conclude 42 sex and age matched couple of ICSI and natural conceived children. 10 pairs additionally matched for the birth wave and twin or singleton. Pregnancy performed the proteomic analysis. The ICSI group had a shorter gestation, more cesarean section, smaller birth wave and length, and advanced maternal age. In this table, you can see that the mother age was significantly higher in ICSI procedure, father was, the age was higher, the gestational age was lower, and the birth age was significantly lower in this baby. We found 19 proteins that this protein are related with acute phase reaction, blood coagulation, and complement pathway activation, and iron and lipid metabolism. And we found overexpressed, and 3 of them were underexpressed. You can see here in this table that the majority was, the 20% was the inflammation reason, the 24% was the coagulation. However, proteomic analysis revealed 19 overexpressed and 3 underexpressed proteins in ICSI. Most of these overexpressed proteins are implicated, as mentioned before, in acute phase reaction, blood coagulation, complement pathway activation, and iron lipid metabolism, suggesting a subclinical unfavorable cardiometabolic profile and supporting necessity of their long-term monitoring. Here, published in PLOS journal, and we examined the ICSI baby, the metabolic profile. We did we found that the urea was and low-grade inflammation marker was lower, and we found high T3. Also, we indicated that there is a clear difference between the two groups, characterized for 36 different metabolites linked to the obesity, insulin-resistant, and metabolic syndrome. Here, in this table, you can see the urea was significantly lower. Also, the T3 was higher, and the inflammation markers was significantly lower. Here you can see the multivariate statistical analysis, and we did the mean of metabolomics data, the biochemical data. Here is the ICSI baby natural conceived, and combined biochemical and metabolic data. The result is that there is a really fair discrimination between natural conceived baby and ICSI. Also, here is the positive significant metabolites, and we conclude that it is the first time that relevant of metabolics was investigated in IVF in ICSI babies. The acquired results are consistent with early insulin resistance of ICSI offspring, paving the way for further systematic investigation. These data support that metabolomics may unravel metabolomic difference between the becoming clinically or biochemical evidence. Underlying this utility is for the ART children, and we have to make more research. And there is, in accordance in our paper, that the age of the babies were between 4 and 14 age, and published a paper in Human Reproduction in 2002, and they showed that ICSI conceived men ages 18 to 24 years, compared with natural conceived, show a difference in some metabolomics parameters, including high resting diastolic blood syndrome, hemostasis model, and for insulin resistance score. However, Mr. Chairman, I will close the conclusion with take message home that altogether, ART is likely to cause some epigenetic changes in the offspring, which might be the molecular base of complex traits and diseases. However, it is still unclear whether these small differences observed in several studies represent a real difference between ART and conceived and natural conceived children. However, large studies with long-term follow-up are needed to fully answer this question. Also, I would like to invite you in the next 29 European Congress will be held in 5 to 7 June in 2025 in Frankfurt, and all you are welcome. Thank you very much for your attention.
Thank you very much, Professor Demetrius, for this nice presentation. Any question for the floor? So now we are going to move to our next speaker, Professor Ameet Patki from India. He's going to address us about day 3 or day 5 transfer. Is there still a debate? Please, Professor Ameet.
No, this is not my talk. This is the talk which got over. Mine is the next talk. Ameet Patki here. Yes. Will you take a picture, please? And then keep the camera here. Thank you very much, and a very good evening to you, ladies and gentlemen, and thank you to Professor Serur for having invited me here to this conference. So today I'm going to discuss about day 3 versus day 5 embryo transfer, and if there is any debate or we should be doing all day 5 or all day 3. Now, what is the goal of any ART treatment? It is to ensure that we get high clinical pregnancy and live birth rates, at the same time ensuring that we get low multiple pregnancy rates. So when we talk about cleavage transfers, there is a risk that there is premature exposure of these early stage embryos to the uterine environment, and that itself can cause some homeostatic stress, resulting in reduced implantation potentials. So when we look at the effects of blastocyst scoring on pregnancy, we know that when you have transferred 2 blastocysts which are more than 3 AA, we have a very excellent clinical pregnancy rate which can go as high as 85%. When you transfer 1 blastocyst which is more than 3 AA, the clinical pregnancies are good, but they range around 69 to 70%. And when you transfer blastocysts which are of poor quality, less than 3 AA, the clinical pregnancy rates comes much lower to almost 43%. So we know that the pregnancy rates are related to the blastocyst grading. And we also know that when you transfer a blastocyst, there is better physiological synchronization between the embryo and the endometrium, because the embryo is at the endometrium when it would have been naturally present. Also, when you're doing a fresh blastocyst transfer, transferring them 5 days after the oocyte retrieval will minimize the exposure to hyperstimulated uterine endometrium, especially when the estrogen levels are extremely high because of stimulation. We also know that the myometrial and the endometrial contractions are reduced post the pickup, and when transfers are done at blastocyst stage, there is a lower risk of the embryos being expelled. And fresh blastocyst transfers are associated with an 8% less hazard of miscarriage than when fresh cleavage embryos are transferred, because they are transferred close to the oocyte retrieval, where there is more of myometrial contractions. But there are several questions which remain unanswered when you do a blastocyst transfer. And the first and the foremost is, would we lose embryos when we try to culture them outside for 5 days? Is it possible that when you transfer a day 2, day 3 embryo, it becomes more better viable in vivo than in vitro?
Conversely, if you transfer a poor quality day 2, day 3 earlier, does it become a good quality blastocyst in vivo? And is poor or no blastocyst development in the lab evidence of poor development potential, or is it something to do with poor in vitro conditions? So these are questions and risks that we take when we try and do a blastocyst transfer. The other risks are, does the prolonged culture in vitro influence the embryo implantation? And as a previous speaker spoke about epigenetics, is there some epigenetic changes when they are kept in vitro in culture medium? And is day 5 transfer the best approach for all good prognosis patients or for all patients, including those where we have only one oocyte or a poor responder? And is day 5 culture of any benefit in comparison to day 2, day 3 culture? And we all know that blastocyst transfer has a high cancellation rate, and we also have fewer embryos to cryopreserve when you think of freezing them at the blastocyst level. What about the obstetric and perinatal outcomes after blastocyst transfer? There is a higher relative risk of preterm and very preterm deliveries when blastocyst transfer has happened. We all know that blastocyst and especially frozen embryo blastocyst transfer is associated with large for gestational age babies. There is increased frequency of monozygotic twinnings when you do a transfer. Extended culture is thought to be responsible. There is an altered sex ratio with a male to female ratio of 1.29, and congenital malformations, the meta-analysis has reported a significantly higher odds of congenital anomalies after blastocyst transfers. So is this subject relevant in clinical practice? Should we be promoting embryo transfer for all at blastocyst? I think it is important not only to look at live birth rates, but we should also look at feto-maternal safety, because that is also something which is important, because there is evidence emerging that outcomes, that birth outcomes can predict diseases in latter stage. So pregnancies which are achieved through IVF, even in singletons, are associated with a higher risk of preterm deliveries, especially those which are conceived spontaneously. And this risk is further increased in pregnancies where the transfer of the embryo is at blastocyst stage as compared to the cleavage stage. An extended culture in women with very few embryos incurs the risk of having no embryos to transfer or very few embryos to cryopreserve for future use. So when you try to balance between blastocyst and cleavage stage, the factors which are favoring blastocyst transfer is only increased live birth rates, but factors which favor cleavage embryo is decreased preterm, decreased large for gestational, decreased monozygotic twinnings. And when you look at cumulative pregnancy rates over 3 transfers, maybe they're almost the same. So what are the issues with day 3 transfer? Day 3 transfers, you need a large number of embryos. It is a traditional method of embryo transfer. We also know that huge expense can be incurred when you try for day 3 transfer. What about day 5 transfer? Is it a solution? Not really, because lesser number of embryos are available. Embryo selection sometimes is easier, so that's a plus point. Natural selection, you may say, when they reach the blastocyst. Better endometrial synchronization, but we have to understand that we need good labs to ensure that we have good culture conditions. We need better and special culture medias. We need trained embryologists, and this may not be available in all IVF centers. So what does the evidence say? Cumulative birth rates after fresh and vitrified cleavage stage versus blastocyst stage embryo transfer in the first treatment cycle says that the cumulative live birth rates were similar for cleavage stage and blastocyst transfers in young patients. So there is no difference between cleavage and blastocyst transfers for the first time and in a fresh cycle. What are the clinical outcomes for day 3 double embryo transfer versus day 5 single or day 6 single embryo transfer in a frozen thought cycle? This is a retrospective comparative analysis of more than 700 cycles. So there were 3 groups: transfer of 2 cleavage stage embryos, or transfer of a single day 5 or day 6 embryo. And you can see that the 2 embryo transfer at cleavage stage gave you a 40% implantation versus a single day 5 which gave you a 54%. But when you look at day 6, if you find that the embryos are slow and they become blastocysts at day 6, the implantation rate dropped to half, that is 25%. So to conclude, significantly higher implantation rates in day 5 single blastocyst as compared with day 3 double embryo transfer. Blastocyst culture is an effective method for selecting embryos with the most promising developmental potential. Biochemical pregnancies, clinical pregnancies, and ongoing pregnancy rates were not significantly different. Twin pregnancy rates and the risk of preterms were lower in the single day 5 as compared to a day 3 double embryo transfer. So when we all talk about reducing the twin rates, the best method would be to transfer a single embryo in most direct approach for a reduction in multiple pregnancies. So when you look at a day 3 embryo transfer versus day 5 embryo transfer, this is a prospective randomized control study published in 2017 with almost 218 patients were selected, again day 3 versus day 5 versus day 6. We found that the success rates in day 3, if you look at live birth rates, it's 36%. When you look at day 5 transfers, it is 34%. So this paper concluded to say that failed to detect any statistically significant differences in implantation, clinical pregnancy rates, or live birth rates in day 3 or day 5 transfers. So what does meta-analysis show? So when you look at a meta-analysis, 32 randomized control trials, over 5,000 couples, multiple outcomes are studied, but we look at clinical pregnancy rates and multiple pregnancy rates. We find that the clinical pregnancy rates were higher in the blastocyst transfer following fresh transfer. If 39% of women achieve a clinical pregnancy after fresh cleavage stage transfer, around 42 to 47 will probably do after a fresh blastocyst transfer. What about live birth rates? Live birth rates following fresh transfer was higher in the blastocyst stage. So if 31% achieve live birth rates after fresh cleavage transfer, between 32 and 41% would achieve after blastocyst transfer. What about multiple pregnancy rates? Uncertain whether blastocyst transfer increases multiple pregnancy rates. Uncertain whether blastostage transfer increases miscarriage rates. But we know that the monozygotic twinning rates are increased in blastocyst transfers. Impact of vitrification. There is a study to show that vitrification could increase the clinical pregnancy rates. So blastocyst transfer in a frozen cycle seems to give you a better clinical pregnancy rates and a live birth rate than a fresh blastocyst transfer. What are the guidelines from the new ESHRE? the new ESHRE guideline says that the number to be transferred is an elective single embryo transfer is a preferred approach for a safe and effective ART. And if you plan to transfer more than one embryo, I think the couple should be specially counseled for higher risk of pregnancy loss, ectopic pregnancies, preeclampsias, gestational diabetes, postpartum hemorrhage. And they also say that you need to take a separate consent if you transfer more than one embryo. In fresh cleavage stage embryo transfer, the decision to transfer double embryos instead of an elective single embryo should not be based on embryo criteria, which means that if you have somewhat not very good embryos, you should be transferring still only single embryo, unless if you look at the woman's age and if she is more than 40, you may consider other criteria, previous failures, to do a double transfer instead of a single elective cleavage stage transfers. But in fresh blastocyst transfer rates, the decision to perform double embryo instead of an elective single again should not be based on the blastocyst morphology or quality, but should be based on other criteria. In cryopreserved warmed cleavage stage embryo transfer, the decision to transfer double embryo should not be based again on embryo quality, and the same goes on the blastocyst transfer. Single embryo should be applied regardless of the quality of the vitrified blastocyst. So the ESHRE guidelines are very particular in emphasizing single embryo transfer, whether it is fresh or frozen, cleavage stage or blastocyst, unless if you have other criteria where you are compelled to do a double embryo transfer. The ESHRE guideline says it is important to consider the increased direct costs which are related to obstetric outcome of multiple pregnancies and pediatric care of twins and high order pregnancies, and the indirect cost in multiple pregnancies, sick leaves, over-the-counter medications, and loss of productivity because of an ill child at home. So to conclude, day 3 embryo transfer is the traditional approach, but you need more embryos to transfer, greater risk of multiple pregnancy and its attendant complications. Day 5 transfer is the current modern scientific approach, but requires good culture conditions and a good number of embryos to start with, has the potential to reduce multifetal gestation and obstetric issues. Good quality evidence is still lacking, but widespread adoption of a single elective blastocyst transfer should be the day of order. I invite you to 2 conferences, the first one on the World Congress on Recurrent Pregnancy Loss in Singapore, January 16 to 19th, and the second conference, which is much awaited in India, the ISAR annual conference, 7 to 9th February in the beautiful and the royal city of Lucknow near New Delhi. Thank you very much for a patient hearing.